just because we've been talking about some of these clinical trials, Dr. Bott, what are your general thoughts about the MURANO study and how that sort of helped with, the introduction of venetoclax into the CLL landscape?
So just to give a background of the MURANO study was a randomized study in the relapsed setting. That means patients had received prior treatment. And this compared the regimen of venetoclax, which was given for 2 years, combined with rituximab as an anti-CD20 monoclonal antibody. And this was compared to bendamustine plus rituximab, which was chemoimmunotherapy at that time. And these were patients who were not exposed to targeted agents. So this is an older study. So at that time, we did not have patients who were exposed. So not truly today's population. These patients were not exposed to targeted agents and definitely showed superiority of venetoclax plus rituximab over chemoimmunotherapy in these patients. So it led to the first approval of venetoclax for CLL in the relapsed setting, and since then things have moved along. We now use it frontline for patients. So the question is more for sequencing, and we can go both ways. For patients who have been treated in the frontline setting with BTK inhibitor, covalent BTK inhibitor, we have now the choice, based on the MURANO data we used to use venetoclax plus rituximab. Data has shown that rituximab may not be the better anti-CD20. Now we replace rituximab with obinutuzumab for that. So that's what we used to do for those patients who were relapsing with a covalent BTK inhibitor. Now, with the pirtobrutinib data that we have, that sequencing, we may see that sequencing change. So that is what I foresee, that patient may be getting acala, zanu, progressing, maybe going to pirtobrutinib, and then maybe getting venetoclax. Then for patients who start with venetoclax obinutuzumab in the frontline setting, that's the CLL14, what happens to those patients? So we talked about retreatment. That'll be based on when they relapse. If they relapse within 2 years, those are the patients probably I would not retreat. Patients who are relapsing 5 years out, I would consider retreatment. So not typically a MURANO population, but kind of doing the MURANO for them at that point, and then introducing the BTK inhibitors later on. So I think these are evolving things that we are learning about our patients with CLL, but the options are expanding.
Yeah, a lot of complexity.
It'll be very exciting to see too as sonrotoclax continues to be developed and brought into the conversations.
Yeah.
We know that that's more potent, safer, easier to ramp up, and how that will change our discussions with patients and sequencing of treatments. Still to be determined, but exciting.
Yeah, and since we're talking about BH3 mimetics, we know we have venetoclax, sonrotoclax, and there's other BCL2 inhibitors being studied. What about sort of a same family-ish, but just a different target, the MCL1 inhibitors? Haven't seen as much of those sort of in practice, even though several years ago there was quite a few being studied. How do you see the MCL1 inhibitors integrated into CLL practice, if at all?
So MCL1 inhibitors, there was interest in them, and there is logic, there's rationale for using them. But I think, if I remember the studies, the initial studies showed limited monotherapy activity, and then there was some cardiac toxicity that was seen. So that actually slowed down the development. I think there is interest in using it in combination with venetoclax because there is dependence with venetoclax. So you want to use that mechanism. So there may be, I'm not aware of clinical trials, but that may be one of the things that a good MCL1 inhibitor without the cardiac toxicity may be combined with venetoclax to overcome some of the resistance mechanisms.
So Dr. Chang, just a question, not necessarily about the target, but just to think, if you have an appropriate target, but unnecessary toxicity, very similar to what we see with the PI3 kinase inhibitors, given how long CLL patients live and a difference between curative versus non-curative, how do you see, if any, these sort of really, really toxic treatments, even if they are effective, sort of fit into the space? I mean, is it something that you would even consider for your patients?
I think it depends on the situation, right? Because if you have a patient who is progressing very rapidly and you need some rapid control and you don't have these sort of safer treatments, then you might be able to use it like how I alluded to with PI3 kinase. The effectiveness is there, and so that's why we can reach to them for short term in order to get them to something else that hopefully will be safer and also efficacious. I think that MCL1 inhibitors, for example, or if there are other BH3 mimetics in development, I think that all those could potentially be very useful. We do know that particularly patients who progress on our current BCL2 inhibitors, one of the ways in which they progress is by sort of ditching the BCL2 dependency and becoming dependent on some of these other pathways. And so if we can actually target those, it can be very useful. But I agree, I think a lot more needs to be studied. I think many of these drugs are very early in development, and we'll see how many of these can end up in clinical use.
Yeah, I'd just like to add to that. I think we're very fortunate to be in an era where we have multiple effective options to reach for our patients, many of which have very favorable safety profiles. But we have to consider that safety and tolerability are different. They're distinct entities. And as we're developing treatments and thinking about combinations, that question of tolerability really does have to be at the forefront, and considering things like risk for infections. These things in practice will become increasingly important for most of our patients.
This is a wonderful discussion. I think we've covered quite a bit of topics. I think in the last sort of several minutes, if you guys just want to just summarize, like, what do you think are the key takeaways with where we are today and where we may be going with CLL?
Yeah, I think the key takeaway, particularly in the routine clinical practice setting, is that I think all of us would agree that obtaining these genomic markers early on is really important, because it allows the physicians, and also if they end up going to another institution for second opinions, for example, to understand better what kind of therapies they've gotten, what are the therapies that they will benefit the most, and how to potentially sequence these therapies, what to expect in terms of when we start a therapy. Do we need to plan for another therapy very soon or not, right? And the main therapies that are being used in routine practice are the covalent and non-covalent BTK inhibitors, BCL2 inhibitors. How do we use them? I think that that it really depends on the patient that sits in front of you, and does require quite a bit of education to the patient and conversations to understand what are the benefits and the risk, and what the patient preference is on any given therapy.
Just to build on that, I think for all of us that work in helping to care for patients with CLL and trials, we do it because until we have the right treatment for all our patients to get them to a normal life expectancy, both in years and good quality years without a lot of complications, then we still have more work to do. And I think we've made a lot of progress, but the trials are still important because there still are our patients that don't unfortunately get to where we would like them to be. We didn't today really delve into Richter's transformation, but of course there's that group of patients. There's patients with high risk markers. We again didn't get into talk beyond TP53-17P, those patients. And young fit patients, I think that's a lot of years that we have to know that we can sequence them. But on the flip side, don't want to take away from the fact that our decision for frontline therapy, for many patients, they might only need that one therapy, especially or one or two initial therapies. So this question of how to sequence them is very important, because we have to get it right for all our patients and get the right treatments and more treatments for all our patients. But for many patients, the sequencing, I think, is less critical. Fortunately, have good options there.
Yeah, I think that CLL is a very heterogeneous disease, not only based on biology, but also based on the characteristics of our patients that we see. As you mentioned, fit or unfit, older, younger, are they close to our centers? Are they coming from far away? And as we have increasing access to diagnostics, using all of the information that we have available to best optimize treatment selection for patients, taking into account multiple factors, right? IGHV mutational status, P53 mutational status, Notch1, complex karyotype, using that information, but also trying to come up with therapies that will address the needs of the patient that you have. And there are a lot of factors that need to be taken into account, but increasingly as a community, I think we're collecting that data where we're starting to be able to answer some of these questions. And at least in my practice, I think that I will have more confidence in thinking about fixed duration regimens in populations where previously I might not have considered that. And so just expanding options, more precision-like treatment for patients.
Yeah, I agree with all of that. And I think in this time, the goal of a modern oncologist is to try to get away from the classical chemoimmunotherapy. And I think in CLL, we have done just that. I think that is remarkable. We use targeted agents. We should not be using chemoimmunotherapy. And our patients with these very effective yet highly tolerated drugs, our patients are leading nearly normal lives. We have multiple studies that have shown the concept. Although we're not curing our patients, we have that functional cure. So I think we all should be proud of that our patients are able to do that. We still have a lot of work to do, but I think we are in a very good place.
Yeah, great. Exciting times, promising future.
Yeah.
So on behalf of my co-panelists, I'd like to thank you all for joining us this afternoon, and look forward to have more exciting CLL discussions with you guys in the future.
Thank you.
Thank you.
Thank you.